Today we're going to start talking about myelodysplastic syndromes. Myelodysplastic syndromes, or MDS, are considered to be primary neoplastic pluripotent stem cell disorders. In this particular disorder, you have one or more peripheral blood cytopenias and prominent maturation abnormalities. Now, these abnormalities are called dyspoesis or dysplasia in the bone marrow. Peripheral blood cytopenias result from ineffective hematopoiesis, increased apoptosis, which is evidenced by accompanying bone marrow hyperplasia. So, MDS usually occurs more commonly in elderly individuals. As we mentioned, it is clonal hematological disorders. We've talked about having cytopenias. We've talked about dysplasia so far, and this dysplasia is an erythroid, myeloid, or megakaryocytic maturation. We will start with a case study that is listed in your textbook of a 43-year-old man who is experiencing fatigue and malaise. He has pancytopenia with a WBC count of 2.2 times 10 power 9 per liter, a low hemoglobin of 6.1 grams per DL, platelet which is low at 51 times 10 to the power 9 per liter, and the differential is essentially normal. Mean cell volume is 132 femtoliters. Vitamin B12 is 377 picograms. It's within the normal range. RBC folate is 259 nanograms per mil, and the normals are greater than 120 nanograms.
Let's look at the peripheral blood film for this patient. The slide on the left shows us the red blood cells that we see under the microscope. You see variations in shapes and sizes of the red blood cell, dimorphic population for sure. Let's look at the slide on the right. You see the myelodysplastic red blood cells and large red blood cells compared with the when you have a lymphocyte in the picture. So a megaloblastoid picture here for the patient.
Now, the bone marrow for this patient is normal cellular with a myeloid to erythroid ratio 1:1, adequate megakaryocytes. Erythroid components are dysplastic with megaloblastic features again that we saw in the earlier slide. Chromosome analysis indicates a direct duplication of chromosome 1q, the long arm 1q. Patient was maintained with transfusions over the next 6 years. The bone marrows revealed increased erythropoiesis, decreased granulopoiesis, and megakaryopoiesis with dysplastic changes. They were 50 to 60% ringed sideroblasts. Okay, so keep these factors in mind. These are the ringed sideroblasts, and with the hemosiderin crystals 2 to 3 plus. Questions that you need to think about as you go through the chapter. What should be included in the differential diagnosis of a patient with pancytopenia and elevated MCV? What would you have seen in another disorder where you would have elevated MCV? Now, here in this patient you have a normal vitamin B12 and folic acid. So what is the patient's probable diagnosis? What classification does this disorder belong? So let's look at what is involved in myelodysplastic syndromes. In myelodysplastic syndrome, you have, as we started off, can be as a result of therapy, or it can be as a result that it's de novo, it's a primary myelodysplastic syndrome. They are a group of heterogeneous diseases that result in proliferation of abnormal stem cells. These proliferation of stem cells have acquired a defect that prevents them from differentiating, maturing, and proliferating normally. The stem cell abnormality most often involves the myeloid progenitor cells. So it's the myeloid, erythroid, or the megakaryocytic cells that are involved, and usually not the lymphocytic cell lines. The afflicted stem cells do differentiate into mature cells. However, they will exhibit flawed and ineffective progression, so their numbers decrease in the peripheral blood, a phenomenon which we call ineffective erythrohematopoiesis. We see the abnormal morphology. Reasons that a patient might have myelodysplastic syndrome can be several. The abnormal stem cell may be as a result of cumulative effects of the environmental exposure in susceptible individuals. Mutation may be caused by chemical insult or radiation or viral infection. Smoking has also been linked with myelodysplastic syndrome. An association with inherited hematologic disorders has also been found. Mutated cells produce pathologic clone of cells, expands in size at the expense of normal cell production. Now remember, the two common morphologic features that we mentioned in slide number 1 is the progressive cytopenias despite cellular bone marrow, and second is dysbiosis in one or more cell lines. Also on the slide, we had mentioned apoptosis, which we have defined in an earlier lecture. Apoptosis is the fact that this is programmed cell death, and if there is a disruption in this process, this can lead to ineffective hematopoiesis. Now, other factors that we need to consider in the case of MDS include levels of anti-angiogenic cytokines, tumor necrosis factor, and cellular components of immune system. Now, we've seen patients with MDS that have increased levels of angiogenic growth factors, including vascular endothelial growth factors. We've seen patients that have had therapy in the past, such as chemotherapy or radiotherapy, and they have an onset of therapy-related MDS, which can be usually 2.5 to 5.0 years after the therapy was initiated. Important to remember, therapy-related MDS is much more aggressive. Now, the cells that are involved, we mentioned, are the myeloid cells that are involved and end up with dysplastic morphologic features. So, in erythrocytes, you have dyserythropoiesis, you have dysmyelopoiesis, or dysmegakaryopoiesis. Dyserythropoiesis. In patients with MDS, we find that in the peripheral blood, the mobile macrocytes. The cells are oval, however, there is normal vitamin B12 and folate values. So therefore, when we see these oval macrocytes, MDS should be included in the differential diagnosis. You see hypochromic microcytes in the presence of adequate iron stores. The dimorphic red cell picture that you see in figure 35.2 on the right, the picture on the bottom, is another indication of the clonality of this disease. So there's poikilocytosis, basophilic stippling, Howell-Jolly bodies, and siderocytes, which are indications that the erythrocyte has undergone abnormal development. Patients with MDS usually have anemia. Oval macrocytes are seen, as we mentioned earlier. In the bone marrow now, let's look at the bone marrow. You'll see red blood cell precursors with more than one nucleus or abnormal nuclear shapes. The normally round nucleus have lobes or buds to them. Nuclear fragmentation may occur. There's internuclear bridging that occasionally occurs. Abnormal cytoplasmic features would show the basophilic stippling that you saw in an earlier slide. Heterogeneous staining. Ringed sideroblast is a common finding here. The megaloblastoid cellular development in the presence of normal vitamin B12 and folic acid is an indication of MDS. So important to remember now, for dyserythropoiesis, patients that have MDS, there is a degree of anemia. Hemoglobin is usually about less than 10 grams per dl. They are macrocytic, they are oval macrocytes. You see the nuclear cytoplasmic asynchrony. The chromatin is usually hypercondensed. They are non-responsive to vitamin B12 or folic acid therapy. Giant multinucleated erythroid precursors. Ringed sideroblasts. So those are some of the characteristics in the erythrocyte arena. Now let's look at dysmyelopoiesis. Dysmyelopoiesis in the peripheral blood is the persistence of basophilia in the cytoplasm, as you can see on the right. Otherwise, the cells are mature, only that the cytoplasm is basophilic. In other words, there's nuclear cytoplasmic asynchrony, abnormal granulation of the cytoplasm of neutrophils. You see larger than normal granules or hypogranulation, or the absence of granules is common in these patients. So you'd see agranular bands. Abnormal nuclear features might be hypersegmentation, or nuclear rings. In the bone marrow, you see nucleocytoplasmic asynchrony, as you can see over here. The cells on the right are showing you the cells in the bone marrow. You see uneven staining with such as a dense ring of basophilia around the periphery. The picture on the left top. You might see areas where some parts of the cytoplasm remain stained normally. Primary granules. There's abnormal granulation of the cytoplasm in which the promyelocytes and myelocytes are devoid of primary granules. Primary granules may be larger than or absent. You might see an occasional auroid. Agranular promyelocyte can be mistaken for blasts. Miscalcification can occur. Bone marrow may exhibit granulocytic hypoplasia and hyperplasia. Now, dysmegakaryopoiesis. Platelets also exhibit dyspoietic features. The megakaryocytes. Common changes include giant platelets, as you can see in the pictures, abnormal platelet granulation, either hypo or agranulation. Some platelets contain large fused granules. Megakaryocytic, the bone marrow shows abnormal morphology, as we can see here. Large mononuclear megakaryocyte, micromegakaryocytes, and megakaryoblast. So now let's look at some of the differential diagnoses that we need to consider when we look at MDS patient. Just looking at dysplasia itself is not sufficient to be an evidence for MDS. So some of the other things that we need to look at is patients that have vitamin B12 folic acid deficiency, which can cause pancytopenia and dysplasia, and exposure to heavy metals. Copper deficiency may also cause reversible myelodysplasia. Congenital hematologic disorders such as Fanconi's anemia and congenital dyserythropoietic anemia may also cause dysplasia. Parvovirus B19 chemotherapy agents also cause dysplasia. PNH, paroxysmal nocturnal hemoglobinuria, also causes similar features. Exposure to some drugs and chemicals is also can essentially cause this kind of disorder. So the abnormal cell functions that we see in MDS. In the granulocytes, the problem with the granulocytes here is they may have decreased adhesion, deficient phagocytosis, decreased chemotaxis, impaired microbicidal capacity. They have decreased level of myeloperoxidase, alkaline phosphatase have been found. Now leukocytes, which is the second most common cytoneutropenia, is the second most common cytopenia observed in MDS patient. About 50% of the patient at the time of diagnosis will have neutropenia. Neutropenia can be accompanied by a shift to the left in these patients. And we've talked about some of the abnormalities seen in neutrophils, where there is agranular or hypogranular neutrophils. You'll see persistent basophils. In these cases, you also see pseudo-Pelger-Hewitt cells that we've talked about in the past. So keep that in mind. Remember, these patients will have decreased myeloperoxidase, decreased LAP scores. Now let's look at the erythrocytes. The erythrocytes have a shortened survival, so you would see erythroid precursors may have decreased response to erythropoietin, leading to anemia in these cases. Now, what about the platelets? Platelets, you have, because of the dysfunction in the platelets, you have bleeding that occurs despite adequate platelet numbers. So there is here qualitative defect. You might see giant platelets, hypogranular platelets, and platelets with large fused granules can be seen. Now let's talk about classification of the myelodysplastic syndromes. FAB classification have 5 classes of MDS, each with specific set of morphologic criteria. The categories are defined by the amount of dysplasia and number of blasts in the bone marrow. So we have here refractory anemia with ringed sideroblasts. Now remember, we talked about ringed sideroblasts in an earlier slide as well. Then we have refractory anemia with excess blasts, chronic myelomonocytic leukemia, and refractive anemia with excess blasts in transformation. The World Health Organization now has added some additional classification. It retains many of the FAB features while recognizing the molecular, cytogenetic, and immunologic characteristics of these orders. They remove the problematic categories of CMML and RAEBT, which is the chronic myelomonocytic leukemia and the refractive anemia with excess blasts in transformation, and place them in the MDS/MPD category and acute leukemia category. So here is a box from your textbook, box 35-4, that gives you the categorization by the World Health Organization. Important to mention here is that the original modification from the FAB classification of MDS included a reduction in the percentage of blasts required to diagnose for acute myeloid leukemia from 30% to 20%. And they have 2 new classification, that is a refractory cytopenia with multilineage dysplasia and the deletion of 5q syndrome. So let's start looking at but at the disorders that we have mentioned earlier. The first one being refractory cytopenia with unilineage dysplasia, RCUD. In patients that have RCUD, you'll see cytopenia, fatigue, shortness of breath, if there is anemia, increased infections from neutropenia, petechiae, bruising, and bleeding of if thrombocytopenia is present. This category includes MDS cases with fewer than 1% blasts in the peripheral blood, fewer than 5% blasts in the bone marrow. Dysplasia might be present in more than 10% of a single myeloid lineage. Okay, unilineage, one myeloid lineage will have dysplasia. And there is refractory anemia with only dyserythropoiesis. Fewer than 15% ringed sideroblasts. There's refractive neutropenia, refractory thrombocytopenia. Median survival in these patients is 2 to 5 years. 2 to 5 years with only a 2% risk of transforming to acute leukemia. So let's move on to the next MDS disorder, refractory anemia with ringed sideroblasts in or RARS. There's anemia in these patients, and there's dyserythropoiesis that is present. And more than 15% of the bone marrow, in this case, more than 15% of the bone marrow erythroid precursors are ringed sideroblasts. You see a diagram of it on the right. To be considered a ringed sideroblast, the erythroid precursor must have 5 or more iron granules per cell. This iron-containing mitochondria must circle at least 1/3 of the nucleus. And you can see the arrows showing that in the blood picture. Peripheral blood picture must show a dimorphic picture with a population of hyperchromic cells and with the majority of normochromic cells as well. So you have hyperchromic RBCs and normochromic cells, but you want to see more of the normochromic cells. RARS occurs in older population. Mean survival is 69 to 108 months. Next one that we're going to talk about is refractory cytopenia with multilineage dysplasia, RCMD. This is characterized by one or more cytopenias, dysplasia in 2 or more of the myeloid cell lines. Remember, multilineage dysplasia. Here you have less than 1% blast in the peripheral blood, fewer than 5% blast in the bone marrow. In RCMD, the myeloblasts do not contain our rods. Now remember what our rods were? We had discussed earlier. Our rods are found in the myeloid series. If our rods are noted, this disorder could be classified now as RAEB2, which we'll be talking in the next slide. In RCMD, you might have more than 15% ringed sideroblasts. Important to remember, dyspoiesis in more than the erythroid line places it in RCMD, again multilineage dysplasia, rather than the RARS, where you have the erythroid precursors that are the ringed sideroblasts. And there's a dyserythropoiesis present. In the earlier slide, we've talked about them. Distinction is important between the RCMD and the RARS category because RCMD is a more aggressive course than RARS. Now the following slide, right here we're going to talk about refractory anemia with excess of blasts. So there are trilineage cytopenias as well as significant dysmyelopoiesis, dysmegakaryopoiesis. Or you could have both. You could have a trilineage cytopenia, low counts, and you could have together with it dysmyelopoiesis and dysmegakaryopoiesis in RAEB. The peripheral blood must contain 2 to 19% blast. Bone marrow blast numbers must be 5 to 19%. 2 to 9 in the peripheral blood, 5 to 19 in the bone marrow. 2 to 19 in the peripheral blood. Now, RAB is distinguished from RCMD, the previous slide, by the myeloblast percentage. There are significant differences in the survival and evolution to AML that may occur. RAEB is divided into 2 types. You have the RAEB1 and RAEB2, and the differentiating factor is the number of blasts. RAEB1, you have 5 to 9% blasts in the bone marrow, 2 to 4% blasts in the peripheral blood. RAEB2, you have 10 to 19 blasts in the bone marrow and 5 to 19 blasts in the peripheral blood. When you have RAEB with greater than 10% myeloblasts, it's much more aggressive course. Now, the next slide we will talk about myelodysplastic syndrome with the isolated deletion of 5q or the 5q minus syndrome. Now, in patients who have only the deletion of 5q, MDS represents a fairly well-defined syndrome, affects predominantly women. The median age is 67 years old. They have typically refractory anemia with no other cytopenias or thrombocytosis. Hypolobulated megakaryocytes, erythroid hypoplasia. Fewer than 1% blasts in the peripheral blood. Our rods are not seen. Patient with MDS with isolated deletion of 5q. They have long-term stable disease, median survival 145 months. In this particular disorder, thalidomide analog lenalidomide has proven to be effective. Now let's talk about myelodysplastic syndrome, which is unclassified. It lacks the specific changes for classification into the other disorders. Examples are cases of RCUD or RCMD with 1% myeloblasts in the bloods, MDS with pancytopenia and dysplasia, limited to one cell lineage, or patients with no increase in blasts, persistent cytopenias. So now let's talk about childhood myelodysplasia. This is a de novo MDS. It's rare. It accounts for less than 5% of the cases of hematopoietic neoplasms in children. They have some characteristics of adult MDS, but there are also distinct differences. This is a table that I've quoted. Professor Rodak has come up with this, where there are all the 5 disorders that we've talked about, showing refractory anemia with ringed sideroblasts, refractory anemia with excess blasts, refractory cytopenia with multilineage dysplasia, and then you have the myelodysplastic syndrome with isolated deletion of 5q. Go ahead and look at this, add to this table what we have talked in the previous slides. Look at the questions you have at the back of the book to review what you have here in the tables. So let's move on to the group that we call the myelodysplastic myeloproliferative neoplasms. These include myeloid neoplasms with clinical, laboratory, and morphologic features that are characteristic of both MDS and myeloproliferative neoplasms. And the group that fall into this is the chronic myelomonocytic leukemia, atypical chronic myeloid leukemia, juvenile myelomonocytic leukemia, and MDS-MPN unclassified. So we have a table here that talks a bit about the 4 disorders that I've just mentioned. CMML, the first one, chronic myelomonocytic leukemia, has persistent monocytosis of more than 1 times 10 power 9 monocytes per liter. There's absence of BCR-ABL1 fusion gene. Fewer than 20% blasts and promonocytes in the peripheral blood and in the bone marrow. Dysplasia in one or more of the myeloid cell line. Patients have increased leukocyte count with absolute monocytosis. There's disc granular poiesis is evident. Neutrophil precursors make up fewer than 10% of the total leukocytes. Splenomegaly may be present due to infiltration of the leukemic cells. Now, prognosis in these patients depends on the number of blasts plus the promonocytes. Let's look at atypical chronic myeloid leukemia. In this patients also you have BCR-ABL1 negative. This is also called the atypical CML. You have leukocytosis, morphologically dysplastic neutrophils and their precursors are seen here. In these cases you will also see the Pelger-Hewitt-like cells. Now the Pelger-Hewitt-like cells show hypogranularity, bizarre segmentation. Dysbiosis is seen in all cell lines. Patients with ACML have poor prognosis when they progress to AML. Now, juvenile myelomonocytic leukemia is a clonal disorder characterized by proliferation of granulocytic monocytic cell line. Happens with kids with 1 month to 14 years. Strong association with neurofibromatosis type 1. Allogeneic stem cell transplantation has been effective in about 50% of the cases. Now you have myelodysplastic myeloproliferative, and these are individuals that don't fit into any of the other criteria. So let's look at the pathogenesis behind MDS. Now we've talked about MDS either being de novo, that is if it is primary in nature. In these cases, abnormal stem cells arises de novo. The patient has no known history of exposure to chemotherapy or radiation therapy. However, myelodysplastic syndromes are acquired neoplasms and environmental insults such as exposure to genotoxic chemicals, radiation, viral infection can be etiological agents that contribute to MDS development. Now, dysplastic stem cell of secondary or therapy-related MDS after chemotherapy with alkylating agents or topoisomerase II inhibitors can also cause MDS. Those are therapy-related MDS. Patients that have been treated for lymphoma or other kinds of solid tumors. So we are looking now at some of the cytogenetic, epigenetics, or single gene mutations. You have on this slide here deletion of 5q, which is the most frequently noted genetic abnormality in MDS. Then you have deletion of 7 or deletion 7q, and this also occurs about 20% incidence in MDS patients. It has severe refractory cytopenias, increased incidence of severe infections. Then you have trisomy 8, which occurs in about 10% of the MDS patients, where you in this trisomy 8, it's not associated with prior treatment with radiation or alkylating agents. Then you have the other 2 mentioned are the 11 and 8, 11 and 13, 11 and 13 abnormalities of the gene. Then finally you have deletion of long arm chromosome 20 in about 5% of the cases. Then in the following slide we will see molecular alterations. The first one, you have mutations in the tumor suppressor gene P53 associated with secondary MDS. Now remember, normal P53 protein functions to maintain genetic stability in the cell. So when there's a mutation in P53, the MDS patients that have this are linked to poor prognosis. Then you have the RUNX1, which is a regulatory transcription factor for hematopoietic differentiation, and point mutations have been observed in some of the patients with MDS, 20% of them. Now we have here now the prognosis in patients that have MDS, and there are 3 risk groups based on the morphologic subtype and length of survival. You have RCUD and RARS that are considered low risk. The intermediate risk are RCMD and RAEB1. RAEB2 is of the high risk group. Cytogenetic features have been recognized as an important prognostic indicator. So if the patient has 3 or more abnormalities, they fall into the high risk group, or if there's an abnormality in chromosome 7. The intermediate group includes those with all other abnormalities. So 3 criteria, important to remember. 3 criteria are percentage of bone marrow blasts, cytopenias, and cytogenetic features are what produce what we call the International Prognostic Scoring System, or we have the treatment regimen that's been used for patients, and supportive care for the patients. Treatment in MDS patients, as we can see, is going to be challenging because of the older group that happens to have this problem, and they tend to have coexisting illnesses. Supportive care is important in this patients. That's the predominant mode of treatment for MDS patients, unless they qualify for stem cell transplantation. Supportive care include administration of blood products because of cytopenias, prevention of treatment and treatment of infections with antibiotics. We've also see 3 drugs that have been approved, that is lenalidomide and azacitidine and decitabine, that have been used. Low risk MDS, they maintain residual function of the bone marrow given hematopoietic growth factors such as erythropoietin and thrombopoietin. Granulocyte colony stimulating factors are given. Low risk immunosuppressive therapy is given. We also have patients that do not respond to growth factors, and so patients in those cases are given molecular therapy, and some of the options include lenalidomide and farnesyl transferase inhibitors. You have in your textbook on page 541 an explanation of the treatment. We're going to talk now about what are some of the things you need to focus on. For instance, You should know what are the general features of the MDS. Progressive cytopenias, we've talked about dyspoiesis in one or more of the cell lines in myelodysplastic syndrome. You might see some blasts that may be increased in peripheral blood. Generally, they are less than 5%. You see macrocytic red cells that may be present. MCV may be elevated in those cases. White count is usually normal or decreased. What are some of the factors that lead to MDS? We've talked about what could be some of the factors. We've talked about therapy related MDSs. Next, what are the laboratory features that we see in MDS? We see that the maturation of the granulocytes is abnormal. You see that the primary distinguishing feature of various myelodysplastic syndromes, we see the percentage of white blood cell blasts in the bone marrows and peripheral blood. Ringed sideroblasts in the bone marrow and siderocytes in the blood can be seen. What is used as a differential diagnosis? Vitamin B12 deficiency, folate deficiency, folate levels or vitamin B12 levels must be considered. So these are just some of the things you need to think about. Also remember the classes and how many cells there are in each one of the classes, the percentage of bone marrow blasts, number of cytopenias, what are the features of each of the MDSs. Be able to look at the case studies that is included in the front of the textbook. Look at the case study in the review questions at the back. Differentiate the different anemias and cytopenias that categorize them into refractory cytopenia or refractory anemia. Know a little bit about the treatments and the supportive therapy for each one of these disorders.